start things off by asking one or two questions that have already come in. How to approach neutropenia in a CLL patient responding satisfactorily on acalabrutinib. Now, we can only answer questions generally because we don't know the full detail of each individual's medical background. So answers will be general.
Yeah, so general answer is it depends how severe the neutropenia is. But let's say if it is a quite severe neutropenia, maybe the patient has already been in hospital with an infection as a result of that, then trying to give G-CSF, which is a hormone under the skin that boosts the neutrophil count, that might prevent severe infections or readmission into hospital. Prophylactic antibiotics is something else that can be considered. Of course, reducing the dose of the acalabrutinib and then re-exposing, re-challenging with a higher dose after a while to see whether it's actually a drug-related side effects or whether it's something else. Because sometimes, as I said, the immune system can go a bit high wire, a bit mad in patients with CLL. So they can also produce antibodies against neutrophils. It's quite rare and it's probably under-recognized, but that can sometimes happen. And of course, for that, then the treatment would be slightly different because you have to suppress that antibody production.
Thank you. Next question, and then I'll go to the hall here. The RSV virus seems to be common post-COVID. It's certainly getting a lot of airtime on radio and the media. I know there's a vaccine available, but it's limited to people, I believe, 75 to 79. Is it something us CLL patients should be concerned about? And from a vaccine perspective, because we're immunocompromised, should that criteria be broadened?
Yeah, I mean, I think, to be honest, I haven't seen any kind of data specifically in CLL patients, but I think, the reason why we see a lot of RSV is also because we're now testing for it on a regular basis. And since the pandemic, we realized that a lot of patients, when they come in with what looks like a virus infection, actually they have got 3 or 4 viruses. What they all do the same thing. They're making your lungs more prone to bacterial superinfection. And so ultimately the pneumonia vaccine is the very important vaccine because that prevents the bugs from coming, from giving you the bacterial infection that is so dangerous. But certainly kind of going a step ahead, being ahead of the bugs and saying we also want to vaccinate against the viruses is a good thing because the RSV virus also weakens your lungs and then they become more prone to bacterial infections.
Okay, if we've got questions from the hall, we'll take a question from the hall just now. Whilst you're making up your mind, I'll ask another question then. So, after treatment, does your staging change, or does it matter?
Mm-hmm. Yeah, it's a good question. So when you look at the original data from Binet and Rai, they said, okay, if you've got stage A disease, then your average overall survival is so-and-so. That was taken from diagnosis. And don't really look at this anymore because this has changed, because this was in the era of when we did not have any treatments that were effectively fighting the CLL. So I would say that the Binet staging, the Rai staging, when it comes to the prognosis, it's useless because we have completely overcome all of that. But when it comes to what is the treatment indication, it's still very useful. So when a patient obviously goes after treatment, hopefully they will go back to having not even stage A CLL, right? Because they don't even have a lymphocyte count that is raised. But when they then progress into a stage A again, they don't need treatment straight away. You can wait. The current recommendations are that you wait until they're back to the stage B or the stage C before you treat. So yes, for treatment indication, very useful. For prognostication, not useful anymore.
Okay. There was also a slightly selfish aspect to that question because I've happily been accepted to do the Chris Hoy Tour de Four cycle in September. So just wanted to make sure I qualified. Right, any questions from the floor?
Yeah, so the studies are ongoing in relapsed refractory CLL, so, and the indications vary from study to study. My personal view on this is that they are very promising. However, I also think that ultimately you will see that they will, similar to the other wonderful drugs we have now, that they will also lead to some form of resistance. Because small molecules, I mean, you know, they will always be that one cell that has a mutation that leads to a binding issue, you know, of the molecule, of the small molecule with the responsible molecule in the B cells. So. Will they ever, the same applies to the non-covalent BTKIs, will they ever replace the covalent BTKIs in the frontline setting? It's very difficult to say, because I don't think there will be head-to-head comparisons, very many head-to-head comparisons. So I think there will probably, and definitely in the UK, because we've got NICE and the NHS and the payer issue, for a long time, you will find that the landscape will be dominated by either continuous second generation or fixed duration therapy. And that will take a long time before those other drugs come into the frontline setting. But they definitely have a role in relapsed refractory disease, because as we are giving more and more doublets or even triplets in the frontline, we are running out of options in the relapsed refractory setting, right? So it's this whole question of, do we need to use everything once at the beginning, or do we sequence? And as people are using more and more venetoclax, ibrutinib, or possibly venetoclax acalabrutinib in the front line, maybe once, then maybe again twice, then the third time round, I suspect you will have to use a biodegrader or something else. I hope that makes sense. I don't see them moving into frontline.
Okay, then, whilst we're waiting for the next question from the hall, why is there apparently 1/3 less incidence of CLL in various parts of the world?
Yeah, so this is a very complicated question. I mean, basically, there's number one, this whole issue of early stage CLL versus late stage CLL. There's then a second issue around access to diagnostic facilities. And for example, China for a long time has said that CLL is very rare. As they are buying flow cytometers, CLL now becomes much more common. Morphology capability, I showed you the picture, it's not something you learn overnight. In the UK, we spent 5 years before we become a hematologist, and a lot of that time is spent on morphology and looking down the microscope. So as we get better in those countries at diagnosing, the incidence of CLL will rise. There's certainly an interesting observation in Japan, where it's very rare, despite the fact that it's also a very old population. And despite that, it's very rare. So people are looking at the genetics of why, in Japan, what makes the genetic component, because even people who migrated from Japan to the States, they still don't get CLL, so it's a genetic thing. Tea, some people were saying, green tea plays a role in making it rarer. There's a little bit of evidence for that. So environmental factors might play a role. There's also, I think, from Africa, there's very little data, but there is some interesting data that basically tells us that, and this comes back to the Burkitt lymphoma question as well, is that when you have malaria, when you live in a region where you get malaria as a very young child, your immune system might be really occupied with malaria, especially the B cells. And so some diseases might become, therefore, disease of the B cells might become more common, and other diseases might be really rare. There's definitely data in multiple myeloma that suggests that multiple myeloma is much more common in people of African descent compared to people of European descent, and I suspect that will be true for CLL as well. Yeah, that's a very good question. So my view, and I think it's probably the view that would be shared by most people, older people, is that you treat the immune complication alone in the first instance. And when that immune complication is under control, you reassess the CLL. Because a lot of the time, these the immune complications are treated with steroids, for example, or with rituximab, and then obviously both of them are very good CLL treatments. And you might find that by the time you've had steroids, you've had rituximab, your platelet count is now 50 rather than 25 or 10. You find that's good enough. The CLL is gone. You don't have any bleeding complications. Yes, it's not a perfect response because it's not 150 but 50, but who cares? Okay, so that's basically the way I look at it. There are, however, patients who, despite having had first-line, second-line treatment for the autoimmune complication, they will still end up with a platelet count of 10, and they still have problems. And so then I think there is a rationale to see, now that we have chemotherapy-free regimen, there's definitely rationale to say, well, why don't we just treat this with a BTK inhibitor to see whether really kind of knocking the CLL on the head actually does the trick. So there's no complete right or wrong, but in the first instance, the first issue is controlling the autoimmune complication. And with ITP, the few platelets that are left are usually functioning really well in CLL. So you can get away with a low platelet count. Where it's more complicated is with autoimmune hemolytic anemia, because there, we still see people, well, maybe not in the UK so much, it's a long time since I last saw people die of autoimmune hemolytic anemia, but in sub-Saharan Africa, where you don't have transfusion support and you don't have, you see people dying from bleeding to death, not bleeding, but basically dying because of anemia, with hemoglobins of 1 or 2, and you can't control the autoimmune complication. So it's really very, very important to be very aggressive with the treatment of the autoimmune complication. The CLL can wait.
A slight tongue-in-cheek perspective on steroids. The very first time I was on steroids, I was hyperactive to the point that I went outside and created a deck. The second time I went to go on steroids, my wife asked for the wallpapering variety, as we had enough decks. Anyway, probably the final question before we go to lunch, and it will come from our Zoom audience. Had a diagnosis of CLL in summer 2020. But I have a long-standing diagnosis of ME/CFS. Am I correct in understanding that I can no longer be considered to have a diagnosis of ME/CSF, as I understand it can only be diagnosed if there are no other causes for severe or life-changing levels of fatigue? I ask, as I notice this is still listed on my medical record as a co-occurring diagnosis. Difficult one to answer, I would think.
Yeah, that's very interesting. I mean, and it's again, it's a sort of under-researched area that would be interesting to get into. We know that there's definitely a correlation with chronic fatigue and EBV, chronic fatigue and CMV. Those viruses, they keep the immune system busy. We have like 40% of our CLL cells fight CMV all day. They just keep it under check, not fight it, they just keep it under check. That's half of our immune system just with one virus occupied. So no wonder people get tired. No wonder we have to also, there's a sort of link between stress and the immune system and sleeping well and feeling better, because, we are exposed to to kind of our viral environment all the time. So that definitely, there's also some people are still saying that possibly all lymphomas are caused by EBV. The Burkitt lymphoma I showed you is caused by EBV, Epstein-Barr virus, which is the most common cause for chronic fatigue. which causes a lot of other lymphomas, Hodgkin's lymphomas, diffuse large B-cell lymphomas. There's evidence that EBV causes other lymphomas. There's also some evidence that EBV might actually also be involved with CLL at the very beginning. So when you get EBV infection as a student, as kissing disease, infectious mononucleosis, that's where you normally get it in this setting, in this country, is in your 20s. And then it stays with you all your life, and it might actually trigger CLL later on. So there's a lot of theories about this, but we haven't got any answers. Now, specifically to your point, I would assume that it's the CLL that has been that's been there in the background, and that's basically caused the chronic fatigue. Of course, we don't know because we don't know, were there any blood tests done, for how long did the chronic fatigue, when did it start, how many years before. So it's very difficult to kind of establish a link or not link.
Okay, thank you very much. Thank you very much, Anna, for your time here today from your very busy schedule. And on behalf of all CLL patients and their partners, can I thank you personally for all the research you're doing. To see the cure word coming up in presentations with some credibility is really giving us hope. And we know that when people come to these conferences or they see us on Zoom, there is always an element of hope. And to see the cure word coming up in the manner it did certainly gives us hope. So thank you very much, Anna, for your time today.